And also this is going to be a very interactive section. So while we basically like learn something new, we'd also like be interacting and also discussing as well. So go ahead and share my screen. I hope all of us can see the screen. All right. Yeah, so the topic for today is AI at the point of care. Basically, what we'll be doing is building an on-device healthcare agent with FHIR. So FHIR, you can think of FHIR as sort of like a data structure that actually stores standardized health information. We'd also be using Cactus. Cactus is an AI inference engine. And basically, we'll be combining these two sort of like best of both worlds to build a clinical decision support system, and also sort of like a tool that could be very essential for community health workers, clinicians, doctors in low resource settings, and also like in urban sort of clinics like Ghana as well. Most of the time when I start with a presentation, I like to basically give like a sneak peek into some of the exciting stuff we'll be talking about. So I'll just basically share something I created purposely for this presentation. So but the looks of this is actually like very simple. We have like a patient, we have Emma, and then we have John. And you open John's sort of like profile. This is basically an EMR system. So you could think of, for example, a condition in, for example, a clinic somewhere in Ghana, basically storing John's profile, their conditions, their medications, their allergies, and everything. We will talk a little bit more about why this is necessary and also like dive very deep into, for example, the best ways to actually store this kind of information. What I'd like for us to do is basically see how, for example, this AI agent we'll be creating actually works or how it performs, right? And basically, we'll also talk about the difference or, for example, the pros and cons between direct LLMs, RAG, and using agents specifically for this use case. So what I'd like to ask, assuming I am a clinician in, say, a clinic in Kumasi, for example, and John is sort of like a frequent patient. He's actually like staying around and he comes around. We actually have his information or data stored, right? In some clinics, they actually use papers. Yeah, it might shock you, but then they actually use paper records. But then we'll also like dive very deep into, for example, how this would help and why this is actually like important, right? And also like build on top of it layer by layer. So maybe John actually comes in again today, and I like to know what medications John is on, right? So these are like pre-populated sort of like questions that I can ask. You could also ask your own custom questions, right? So what is actually happening is that the agent first sort of like looks at John's available information, but instead of looking at every data sort of like one by one, it actually only gets what it needs, right? So you could think of, for example, most of you have actually played with Gemini or ChatGPT. You have like a PDF or whatever, right? And maybe you want to ask about it and then just like dump it all in, right? And then, or whatever LLM you may be using. And then eventually basically like answers the question you want to ask based on the context you provided it, right? So here you can see that instead of actually doing all that, we only get what we need, right? And also this is actually happening on device. So for the purposes of this presentation, I could have switched off the data and this would have worked, right? But then let's not put ourselves through that. It'll be very, very hard to actually come back with the connection. So what actually happened is that there are actually 9 steps involved, different steps involved or number of steps involved, depending on, for example, the question you ask. But here you can see that first, the agent gets the available patient data. So if John has already been, for example, registered in the system, we actually cache it, right, for faster inference. And then the agent actually plans exactly which data to retrieve, right? So instead of actually going in there, right, checking every data one by one, it actually plans what to retrieve, right, what it needs and what it doesn't need, right? And then based on what it actually needs, it selects the tools, right? So we actually look more into, for example, what exactly tools are and how to structure them. And then now, based on the tools, we actually get the information we need and extract the relevant information and then basically present it as a response, right? So this is like sort of like you have a data structure fed into the model. The model does something with it, and then the agent actually like gives you a response back, right? So you could also look more through, for example, the thinking process of the agent, for example, right? And we asked about like the medication the patient is taking, and then it basically like give this answer, right? So mind you, this is not like just a simple chatbot. This is basically sort of like an autonomous sort of like end-to-end system where you have like the data somewhere, right? You look through it and they basically like get the relevant information you need. So this is sort of like a sneak peek into what we would be doing. Maybe you're a clinician, maybe you're a developer, maybe you have some experience, but then the goal today is basically to also open your minds up and also for all of us also like explore the different types of, for example, ways we could solve like rural problems with like AI agents, for example. And you're actually going to do that in a very suitable way and not just like building for building's sake, right? Yeah, so let's get right into it. I hope all of everyone is here with me. I can see we have like some people already. So we'll get right ahead. Yeah, so we have Justice, we have Susan, we have Richard, we have Matthew, we have Dave, and a lot more. So yeah, guys, let's get into it. Really excited for this session, to be honest. Okay. All right, so let's go straight into it. You've already given like an overview about what we're going to talk about. But here is the reality check, right? These are like two studies, one by Stanford, one by MIT. And basically, what these reports or studies actually found out was that most AI agents or generative AI sort of like pilots or applications, while they actually in prototype stage, do very well. I mean, you're building your own thing, but then in the clinical world or clinical setting, what they actually realized was that the sort of like applicability is actually not that good, right? So this report was from MIT that actually basically concluded that 95% of generative AI pilots at companies are failing, right? It's also similar in healthcare as well. So I guess, yeah, now that we know like this information, I guess we should just stop here, right? What do you guys think? There's no need going further, right? Yeah, just kidding. So let's look more into it, right? We are engineers, we are clinicians, we are human beings, we're always curious, right? So why exactly is it, right? What's the reason why they actually fail? So the studies actually, this also specific to, for example, studies that were done at one NYU and Stanford. And basically, the application that they actually built out was a sort of like health system, so EMR system, right, which records patient data. And then to help doctors actually make sense, much more sense about like the very, very large longitudinal patient data, what they actually built was, hey, let's say a patient comes in, right? Let's say Justice comes in, or like any of us comes in to a patient, to a doctor, right? And then the doctor basically like already has like our longitudinal sort of like data, right? But then it would actually like take a very, very long time for them to actually search through the entire data. Let's say you've actually been to this clinic for, say, the past 2 years, right? And for the past 2 years, maybe you've had like 20 visits, right? But then they want to actually make sense of, for example, your healthcare trends or your sort of like longitudinal healthcare data, right? So it'd be very, very difficult for them to just go through all that data. So what the study actually did, or what the solution concerned, was about sort of like a system that would help doctors actually summarize patient data, right? So, hey, Joshua comes in. Okay, the AI basically summarizes like your past medical history, and then the doctor right off the bat has much more better understanding of your medical background, right? But then the reality check is that 19.4% of all the AI generated content, right? Only 19% were actually like used by the doctors, right? Why is that? So the key findings basically was that 80% of all the AI generated drafts were discarded entirely. And the reason why that is because eventually doctors still had to edit the draft, right? Some of them some of the drafts, some of them had like hallucinated data or information or total made up information about the patient. And also the way that, for example, the doctor wanted like the framing to be was also like entirely different, right? So for example, you can think of, say, a patient comes in and the patient actually is just discharged, right? And the doctor basically wants to send like a follow-up message to them about, for example, the visit, right? What was talked about, the next steps, the medications, and all that, the labs and all that, right? But then it turns out that 80% of all those AI-generated drafts were discarded entirely, right? And clinicians also found AI outputs quite much editing, like I explained, right? So the reason why that is, right, is that the systems weren't integrated into clinical workflows, right? So here's the thing. The models actually worked, but the infrastructure didn't. So the problem wasn't like an AI capability issue entirely. It was actually how it was deployed. It was just bolted onto the ER system, and then doctors were basically expected to figure that out, right? Or to basically add that to the direct flow. And most of the time, when you think about users, right, if there is anything you're building that would add like an extra step to their typical workflow, they would sort of like discard it entirely. They wouldn't even use it, right? So that's actually a very interesting study. But then late last year, they actually went even deeper based off of the study they conducted, right? They were like, hey, these are the lessons we learned, right? What can we do better, right? So they realized that it's not a model problem, it's an ecosystem problem. And the first thing is an EHR integration, right? So if you actually don't have the system in place, how do you even expect to integrate your solution into it in the first place, right? So the solution you build should live inside the clinical workflow, not beside it. It shouldn't be bolted beside it. And two, of the takeaways was data quality. So whatever you feed into the model, or whatever you feed into, for example, your system, right, you get as much sort of like level of conciseness or quality back, right? So, for example, if basically the data you feed into your EHR system aren't standardized, for example, you get like data that isn't also standardized or doesn't make sense back. But they also realized, or the lessons of one of the takeaways was to not just bet on one model, right? But to build for any LLM. And these days, there are like lots of open source LLMs out there that are actually like doing really, really well, right? So if you're designing your system, you shouldn't just think about, hey, I'm just gonna stick with this open source model, or hey, I'm just gonna stick with this third-party API and I just build for it. You should make a model agnostic so that you could like sort of like plug and remove like different models from it and basically like experiment with it either way, right? And then the fourth one, which is very important, is most of the time when we are developers, we actually like try to build in isolation, right? We just be like in our working space, our bedroom, or whatever. Then we just be coding and coding and coding, right? But then one of the most important things is also like gaining clinician trust, right? So one, the output actually should be verifiable. It should be cited and it should be reviewable, right? So you can't just like make anything up. The model can't just make anything up and expect the clinician to actually like believe it, right? So you must actually gain the clinician trust. You should actually like ground the output actually comes from the model. So the key takeaway, like I said, was that the chat EHR platform, which we just talked about, embodied all of these, right? It's basically embodied sort of like the standardized structure of the patient data. It was model agnostic and basically embedded into Epic, which basically is one of the biggest EHR systems used. So it wasn't just sort of like a standalone platform that was just booted onto it, right? Okay, so yeah, let's dive a little bit deeper before we go into technical stuffs. So what they get right. First is FHIR native, right? So all patient data. We also talk more about FHIR, what FHIR actually means, what it represents, and what goes into it. So one is all patient data actually flows through FHIR resources. So resources are basically sort of like how you actually structure the higher level representation of the patient data. So for example, the patient resource contains, for example, their demographic, contains, for example, their dates of birth and all that, right? And the observation basically contains like everything about, for example, their visits. The condition represents, for example, the diagnosis. Medication also represents, for example, the medication they were given. So basically structured ways of actually representing all this data. And then two, is that it was model agnostic. So they were able to seamlessly switch out models without changing the data layer or UI, right? So that, hey, tomorrow you decide to sort of like use a different model and just sort of like swap it inside and everything breaks, right? The third one is that it was actually like embedded in an EHR. So like I said, you don't have to boot it on onto like the EHR. You have to like integrate it into the EHR. You have to like embed it into the EHR. You have to live inside it so that it doesn't disrupt the clinician workflow. They don't have to use a different tool all over, right? And then four is structured output. So AI responses include citations back to the source, data in the medical output, right, or medical record. So every claim that was actually sent to the doctor was actually grounded back to the original data, so the doctor was able to verify the source. Yeah, so let's bring it back home. Yeah, like I initially said, there's really hospitals or clinics in Ghana that actually like use paper records, right? Might shock you. So let's bring it back home. So let's say you want to solve this problem, right? You are an innovator. You want to disrupt the healthcare system in Ghana, right? So yeah, you want to like sort of like implement a similar system here, which would one improve continuity of care, two help doctors actually remove some of the burdens that are actually on doctors, especially when they're actually like seeing patients. Sometimes documentation and all that actually takes a lot of time. So yeah, let's bring it back home. So let's say yeah, in a clinic in Ghana, right? Let's take a clinic in Ghana, for example, and let's say there's a community of like who average, let's say, see 40 patients a day, right? So one, the fact of the matter is that the patient's records are in paper folders or scattered across three different systems that don't talk to each other, right? So they are paper-based systems, and also they are records that basically are on sort of like a computer system that no one even sort of like knows what goes into it and what comes out. And when the patient is referred, for example, let's say to Kolebu or Confornoce, their history actually doesn't follow them, right? They're all stuck in silos, right? The second point, basically, or the second sort of like truth of matter is that you want to actually like build like sort of like an AI chatbot, right? And you want to actually help use that AI chatbot to solve or disrupt the healthcare system in Ghana, right? It can basically do that because the infrastructure problem is not solved yet, right? So before you actually build AI to work, you need one structured data interoperability and a standard everyone agrees on so that the system talks to each other in a form that they also understand, right? So the infrastructure problem must be solved first. So you can't just disrupt healthcare with a chatbot. Healthcare is actually very complex with like different layers. There's the clinical workflow, legacy system, data privacy, there's compliance and patient safety, all of that. So people actually solve the boring infrastructure first, right? So the data capture and all that, the processing, the standardization, and then layer AI on top of the solid foundation. So to recap, first, solve the infrastructure problem. First is the data capture. You have to find an efficient way and a standardized way to actually capture the data and digitize it. Two is the data standard. Like we said, to have a system or a way where people actually agree on sort of like the structure of the data and basically everything actually talks to each other in a way, right? And three is interoperability, which is that systems exchange data. So for example, if a patient is referred to another clinic, they know what to expect, right, from the output of your system, right? And the history, patient history and data follows them wherever they go. And then now you can actually start thinking about the AI layer. So now you can build LLMs, your RAG and agentic stuffs on top of it, right? Yeah, so let's actually do something really quick. We are a we have like more than say 15 participants here. Yeah, so let's say Kingsley and Simolua. Sorry if I get your name wrong. So let's say we're gonna form like a team, right? So we have Kingsley, Simolua, we have Engineer Joseph, we have Joshua, we have Elisha, right? And you guys want to disrupt healthcare, right? So maybe you're inspired by the game series and you want to basically like build something that actually solve the healthcare problem, right? So you set out to sort of like do just that, right? So we have the first group, the second group is Herman, Joshua, Mary, Frank. That's also like another subset of group. Then we have Anthony, Dave, Ken, and Akan Basiam. Sorry if I don't pronounce the name rightly. Yeah, can you actually pronounce your name for me? Akan Basiam. Did I get that right? That's a fourth team, by the way. Yeah. Anyway, yeah. So you guys basically want to disrupt healthcare. So you form this team, right? And you want to do just that. So let's say the first group takes over Accra, the second group takes over Kumasi, the third group takes over Tamale, the fourth group takes over Cape Coast, right? So what's actually really interesting is that um, for developers, everyone has, for example, the technology they're familiar with, right? So let's say the first group basically picks React and Supabase as sort of like their stack, right? The Kumasa guys pick Node.js and Firebase. Okay, cool. The third guys pick Django and Postgres. Okay, cool. Then the four guys take Flutter and MongoDB. All right. That sounds good. Um, yeah. So let's say after the end of the year, you guys have actually built something really, really cool that collects patient data, sort of like this really cool EHR system, right? That's going to disrupt healthcare, solve the healthcare problems in Ghana, right? And then at the end of the year, Ghana Health Services actually recognizes they're like, hey, you guys are doing like something really, really cool with all this, right? We actually would like all of you to come together, right? Because we actually need all patient data in one system, right? So let's say at the end of the year, we want to see which communities or which regions have this sort of like prevalence of this disease and which one doesn't, right? Where should we deploy like much more resources, right? And all that. So you guys eventually have to all come together and then integrate your system into each other, right? But here's the thing, every team actually builds something different. Their tech used we're actually totally different. The database system used basically has different schemas. Patient records can't actually flow between regions because now first system doesn't actually know how to talk to the second system, right? So let's say the Accra guys actually stored a patient's name as patient underscore name. The second guys actually stored it using like camel case. So patient's name for the name part, right? So there's actually like an interoperability problem. That means all these systems can basically talk to each other, right? And there's a problem. This is the problem we've been talking about from the start, right? First, there's the paper problem, and then you guys basically set out to solve the paper problem, and then now you have like a whole new problem on your hand. The system can talk to each other, right? So that's a huge problem. So when systems don't talk to each other, patients suffer, right? So there could be duplicate tests. There are allergies that should be flagged that aren't. They're actually very, very crucial because if you actually are able to, for example, determine the allergies of a patient, right, you'd also be able to sort of like determine which medications to give, which treatments to give, and whatnot, right? And referral letters actually also like lost between facilities as well. If, for example, system one refers a patient to sort of like where system two was built, it wouldn't actually work, right? So this basically means that there's no longitudinal view of the patient's information, right, or data. So yeah, then what's the point if we have all these problems that aren't already solved, this interoperability problem, then your AI agent is actually of no use because it can't reason over this data, right? It actually has no idea what all these systems, all these groups, right, how the system integrating into each other and how to actually also make sense of it, right? So yeah, real quick, let's go over what interoperability actually even mean, right? So interoperability means systems can exchange and use data from each other regardless of the technology underneath it. So interoperability in this case means that no matter the tech stack or technology the first team used, it means that the second team can also talk to their system in a way, right? So there are actually four main important parts that we need to think about as developers and also even as clinicians. The first one is foundational. So systems should be able to send or receive data in terms of interoperability. So they should be able to send and receive data. The second one is structural. the data formats should be standardized. There should be a standardized and clear-cut way of basically knowing what to expect from system A or system one, right? And also data meaning is shared. So for example, if this code represents diabetes or malaria in the system, it should be shared. It should also mean the same in another system. And the fourth one is organizational. So governance policies and trust frameworks between institutions and as well. So we've covered a lot already. I would want us to get into the technical bit a bit. Let me introduce you to something called FHIR, right? So FHIR is basically the short-hand form for fast healthcare interoperability resources. We already mentioned resources. We said resources is basically like a bundle of standard way of representing patient data in a way, right? So it's actually pronounced FHIR, like fire. And it's the global standard for healthcare data exchange. So everything is a resource. A patient is a resource, an observation, which is when the patient came in and all that is also a resource. A condition is a resource. If you're a developer, you can think of it as a class, right? A medication is also a resource. So basically a bundled and sort of like standard structured way of representing that patient's information. So they're actually just JSON objects, right? But then they actually have much more standard to it as compared to, for example, how you do that in isolation and then basically create something, sort of like a schema that doesn't have like any standard, right? And they actually connect via references. So for example, if you have like a database, you can actually create like relational databases that actually reference each other, right? And one interesting thing about it is you don't actually like need any different technology to use FHIR. If you're a developer already, you know how to make API requests. You can actually use REST APIs to basically access FHIR right off the bat. So it's actually very popular used around the world for data standardization. And most of the emerging digital health initiatives and systems, even in Ghana, have actually started using it, right? So you will love it. We'll dive right deep into it. Yeah. Okay. So what I'd like for us to do is I'd like to pause here before we get into the technical bit to check if any one of us has like any question. Yeah, or for the groups, you haven't actually sort of like help you with the group I assigned you. Yeah, the group is very important because I'm pretty sure from here we would all be inspired to actually like go build something that actually solves a real problem by incorporating some of the things we will learn here, and also talking to actual like clinicians and sort of like getting their feedback and all that. Are there any questions? Gonna give like 5 seconds to that, and if there are any questions, we would clarify that. Okay. Yeah, if you also have any questions, feel free to put it in the chat. I'll check it out, and yeah, let's get right into it. So we talked about FHIR, right? But let me go back to the slides a bit. We have like a few, and then we would actually come back to what we did mention, and then we'll go through some codes as well. So like I said, maybe let's sort of like expound on what all these resources are. So the first one is patients. So like I said, the patient resource basically encompasses the demographics. So also the name of identifiers, demographics could be, for example, where they live, where they were born and all that, right? And we have the encounter resource. So the encounter resource actually encompasses sort of like the visit when, at what time and all that, when they were admitted, at what particular sort of like point in time did they start having their consultation with the clinician. There's the observation resource, right, which basically contains the vitals, labs, and social history data. There's also the condition resource. This contains the diagnosis, problems, and allergies that the patient basically has, right? And then the fourth one is the medication request. So sort of like the medications they've been on, their current medications, the frequency and dosage and all that. And then the last one is basically the practitioner. So which clinician actually had a consultation with them, which nurse to their vitals, which doctor were they in consultation with, or which community health worker actually took their data, right? So all these are actually like interlinked with each other. So if you basically think about FHIR, it's just like everything here, resources, but then every single bit actually has like the type of information they collect or what is actually represented in it. All right, so this is what a typical FHIR resource looks like. It's just a JSON. If you're a developer, this should be familiar. It's just a JSON, but then it's a much structured or better structured JSON, right? So the first part of a FHIR resource is a resource type. So let's go back. We talked about the patient resource, the encounter resource, the patient resource. This is a typical example of what type of resource. Can anyone answer that? Yeah, real quick, can anyone answer that? What type of resource is this? I can actually mention names. Okay, so this is actually a patient resource. And you can actually identify that with the resource type, right? So the resource type always comes first. It identifies the type of resource, and you have the ID. So, for example, if you're building for Ghana, this could actually easily represent the Ghana card number, right? For example, right, which basically represents the uniqueness of the patients across like different systems, right? And you have the name, which basically structures, for example, the first and last name, the date of birth, the gender, identifier, and all that, right? So again, this ID eventually is, for example, the database ID. You have the identifier, which could easily be, for example, their NHIS number, Ghana card number, and all that, right? So like I said, you don't actually need like any different technology to actually start using FHIR. It's just basically like a REST API that you can actually make requests to. So you could read a patient's data, you could search by their name, you could create new patients, you could update the patient's information. You could also delete the patient and also get all observations of the patient. So, for example, all the visits that they've had at a certain clinic over a period of time, for example, right? Right. Okay. So, what I'd like for us to do is just go right into the technicals, right? So, yeah, there are actually different ways you could actually start using FHIR. Actually, there's one more thing I'd like for us to look at. So, play from current slide. This basically is just going over or summarizing what we just went over. Yeah, but then in short, now with interoperability, regardless of the tech stack or technology that these different people used, because of interoperability, they can all talk to each other. So, for example, at the end of the year, when Ghana Health Service says, "Hey, you guys have actually done a really good job building like all these EMR systems," and we basically want to identify, for example, healthcare trends and prevalence in sort of like a certain region, regardless of the underlying technology that you guys used, right? The different groups that we actually created on the fly, you can actually all using FHIR actually come together and share data integrated together, right? So, for example, if a patient is referred from a specific place to like another hospital or clinic at a specific place as well, because they are interoperable, the system actually like expects the same data back, right? And then now your AI agent actually works, can actually query any patients regardless of region, which is pretty cool to me, to be honest. I don't know about you guys. Yeah. So you can actually start using FHIR right now. There's actually different ways to use that. Some of them are actually open source, so you can actually just look through the code base. There are also some that are actually also hosted, so you can also make direct API calls to. So there's Happy, there's the MedPlum, there's Smart on FHIR, there's the Google Cloud version. But what we'd like to use today is we are going to generate our own patient, sort of like patient data, right? Using which is actually represented in a FHIR format, right? So, for example, if the groups that we created, any of us actually sort of like onboard a patient, register patients, no matter or regardless of the technology we used, a clinic that patient is referred to can also basically expect that or similar data back, right? So let's get right into it. This is going to be super fun, I promise you. It's just going to generate a synthetic patient data using Cynthia. So what is actually Cynthia? Cynthia is actually a synthetic patient population simulator. It's able to generate patient data, realistic patient data, although they are not real, they're made up. But then the structure is actually representative of a realistic patient, right? So add the link here, also in the slides. If one of us wants to look at that, you can actually look at it. So let's get started. First of all, what we'd like to do is that we could actually download a pre-generated Cynthia data. So on their servers, they actually have a pre-generated data that they actually have already, which you can download, but it's actually quite large. So what we'd actually do is basically we'll just run our own simulation, right? So let's make the necessary imports. We are just gonna import the necessary libraries we use. We're going to specify our output directories, and also because it uses Java, let's also go ahead and check our Java version. Here we have Java installed. That's pretty cool. Now what we'd like to do is basically download it if it's not already present, right? But I've already done this, so I should already have it. So there's also the link to the data. If you want to, it would actually help you to generate your own synthetic data. Yeah, so I already have it installed. So the only thing this does is basically it just checks if it already exists. If it doesn't, it just goes ahead and then download it onto your local machine. So here's an interesting bit. Here we want to generate 3 patients, and we actually want to use the FHIR sort of like the FHIR what we talked about, right? The way of basically ensuring that health systems are interoperable, sort of like the standardized way of actually exporting or storing patient data or representing patient data, right? There's actually also different ways of actually doing that, but then we'll stick FHIR for now. So it's actually pretty straightforward. All you have to do is this command with, for example, the number of patients you want. So we just want 3. So I'll just go ahead and then run this. So yeah, it's actually would actually generate synthetic patient data for us in a sec. Okay, there we go. All right. Okay. So it's actually loading the different modules. So like we talked about the different resources, like the patient itself, the medication, the practitioner. So for example, the clinician who actually like took care of them during their visit, right? And all that. Yeah. So let's give this a second. Okay, and you could also notice that this is already in JSON, right? So like I said, you really don't need like any new tech to actually like start using FHIR, right? All right, pretty cool. So the min age is 0. The max age of the synthetic generated data is 140. Okay, cool. All right, let's give it a couple more seconds for it to finish generating our synthetic data for us, and we'll start like exploring it and playing with it. All right, cool. Oh, and mind you, since we're actually using like zero index in Python, it's actually going to generate 4 patients for us, right? Okay, cool. So here, what we would like to do, right, is find exactly where the sort of like FHIR files are, which are also stored as JSON, right? So basically, we are just checking for the JSON data, and we get back this, right? So like I said, it's JSON, but better structured JSON. And now what we'd like to do is basically explore it, right? So yeah, we have resource and then we have resource type. So basically the different resources would like could easily be, for example, the patient resource, which would give us the name because we want to identify the synthetic or simulated patient information provided, right? And also the resource type, which will actually tell us that, hey, this is actually like the patient resource type, right? So let's go ahead and then run that. And we'd actually get like the different resources, even much more than I actually showed before. So here we have the observation resource, right? We have the procedure, we have the diagnostic report, the claim, the explanation of benefit, and a lot more, right? So we've got like lots of rich data that we can actually like play around with. And here, what we'd like to do is, mind you, we have like all these JSON data, right? But then they're actually very data rich. So we can actually like look more into it. Here, let's just look at, for example, the patient resource, for example, right? So a typical patient resource looks like this. So here, what we are just doing is we are grabbing the first patients in our simulated data, right? And then basically viewing what that looks like. So here, you can see it's just a JSON, but better clearly represented JSON, right? So again, we have the resource type, which identifies the type of resource. You have the ID, you have some information that's also relevant. You have the text. Maybe let's scroll down a bit. We'll see some of the things we actually saw, which would actually be a bit more familiar. You have identifier, which will actually uniquely identify the patients, for example. Let's go down. Let's go down. You have the name. Okay, cool. There's their family name, and these are given name, right? So in just a few minutes, we've actually generated the synthetic patient data. And what's really cool with this is even though this is synthetic, if you actually like create a patient in our system or EMR, using like this is similar to, for example, the group 2 that we created on the fly, no matter like how different our underlying tech is, we'd all be able to sort of like view this data and be able to share the context across them, right? Yeah, so that's pretty cool, right? That's pretty cool. What we can also do is we can also look more into the conditions. So again, it's just JSON, but better represented JSON. And the patient basically has the conditions resource type, which is basically their diagnosis, for example, maybe during their visits, right? So let's get the first 5 condition. Okay, cool. Cool. All right. Let's get the medications they're on. So the only thing we actually change in, right, is a resource type, and then that's it, right? So we have the medication. Okay, cool. You could also get like the observations over the period of the visit, right? So the vitals and the labs and all that, right? Yeah, so this is pretty cool. With just a single JSON for a patient, we've been able to get like all this like rich data that we can actually share across like different systems. So let me show you guys something. When I go here, right? We already started with just 2 patients, right? Emma and John. There's actually also simulated data, but also like better represented like UI/UX, right? So we have the condition, the medication, and the allergies, right? And this is basically like just a JSON in the FHIR format, and then we're able to like get like all this information from it, right? So if all of these groups actually like use this sort of like format, it means that no matter the text type that any one of us uses, right, we'd eventually be able to grab that and then render it in like the different ways we want, right? Which I think is pretty cool, to be honest. Yeah, so let's pause here, and let's just go around the table if anyone has any questions. So far, we've actually talked about there's a lot more to talk about, a lot more cool demo to actually also show. And I think you guys will really enjoy it. But then, yeah, I'm gonna pause here very quickly and see if any of us have like any questions. Yep. If you have any questions, you can raise your hand or put it in the chat below. All right, cool. Yeah, let's continue. This is gonna be pretty cool. Yeah, so now you have your data, right? You've essentially solved the interoperability problem in a way, right? So now comes the cool part, right? You can actually add your AI agent or whatever on top of it to sort of like make sense of it, right? We'd get back to it in a minute. So you have your data capture, which is important. Like going way back, we said you need to solve the infrastructure first, right? You need to have a way to actually store the data, capture it in a way that actually eventually layer your sort of like AI on top of it. And then we looked at the FHIR server. Yeah, and then now we can actually go into the interesting stuff, AI, LLM, and all that, and also like the clinical interface, like I just showed with Smith. So to recap, if you have your data, what you'd want to do with an AI agent is AI agent basically acts autonomously. We would see like that in a few seconds. I think we already saw that in the demo, but then we would dive like a bit more deeper into how that actually looks like, right? So, for example, a clinician could ask with a patient reporting for the appointment, hey, what is her latest vitals, right? And then, like I said, instead of actually grabbing all that again, right? Let me actually show you guys something. you see this JSON data, it could actually be very, very large, right? So imagine a patient at a certain clinic who's been basically visiting the clinic for, say, 3 years, right? You can imagine this becoming very, 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 very large, right? So you could have different observations. And yeah, observations are basically like the visits and all that, right? You could have that as an array of JSONs, basically, right? So you could actually imagine this getting very, very large and very, very, very tall. So eventually what we want to do is we don't want to ingest all this into the LLM, right? Most of them actually have very small context windows, especially on LLMs. We'll talk more about that very, very briefly. So what you want to do is you just want to get what you want out from the data and not just like get all the data, right? And this also makes sure that it's actually like very, very fast in a way. So he asks about latest vitals. It actually reasons and basically decides the type of tools to call or the type of endpoints to call, right? And then it returns your data for you, and then you're able to essentially pass that data in a human readable way using, for example, a different LLM. So here we would be using a tool calling model, we'll be using function Gemma, and then we'll be using Gemma for the LLM response. So we've also come across, or we've come at a very crucial juncture, right? Initially, at the very start of the presentation, we actually had too little data. We even didn't have like any data at all, to be honest, because we're all in paper records and siloed somewhere, right? But here's a case that we now have like too much data. So like I said, imagine, for example, a patient longitudinal patient data that's like very, very long, goes back like lots of years, and the clinician wants to make like sense of, for example, their medical data, for example, right? It will take like a while. And there's only so many patients a clinician can see a day, right? So this now is where LLMs make sense, right? What makes sense of the data? So these are potentially many of the ways that LLMs can actually help. They can summarize data. So, for example, condense a 5-year patient's history in a pre-visit brief, right? So even before the patient gets into the consulting room, the clinician already has sort of like a brief summary of your medical history. You can also reason across different symptoms, labs, and all that to flag interactions. So that's something we will also look at. Would be using like clinical decision support to flag drug interactions, right? So LLMs actually like very, very good at that. We can also like draft or generate notes and information and all that. So for example, we'll be able to generate clinical notes, referral letters, patient explanations, right? But if we actually do this really, really well, then we wouldn't face the initial problem that is actually from the study we had, which is from the Stanford and MIT study, right? But we'll be able to build something much more useful. Could also like translate. So, for example, converting medical jargon to patient. There are actually a lot of patients that actually just come back home from their visits and then upload their data to sort of like some LLM to actually just make sense of it, right? So if you actually build something like this really, really well, it would actually benefit like patients, for example, right? And also triaging. So for example, you could think of a community or sort of like a clinic somewhere, right, with a community health worker, and you've created like this really cool diagnostic mobile app where, for example, you could scan sort of like a skin lesion or something, right? Or they could even like get sort of like their chest X-ray and then be able to sort of like triage and escalate when necessary if sort of like for example, if like the issue sort of like is very, very like agents, for example. So, for example, to a district hospital, right? So that was like a really cool, really cool application. The last one is also to educate. So, for example, answering clinical questions and all that. There are patients that have, for example, their medical data on their phones, and there's also like the potential for sort of like talking to that data, right, and getting like much more understanding about, for example, what their medical data actually means, right? So these are actually very, very cool applications. But the most important thing or takeaway here is that how you actually connect the LLM to your data determines everything, right? So what I'm actually going to look at next is the different ways you could actually connect all these sort of like FHIR data that we talked about in a way that would actually like make sense to clinicians and also like help them make sense of the data. So yeah, we're gonna look at three things. But like I did mention, I always like to introduce a new concept with a demo. So let's do that. Let me bring this up. You're still going to use John Smith patients. Yeah, let me switch to sequential. What I was really trying to do here is, for the purposes of time, just to make sure that the models run in parallel instead of sequentially, so that we can actually see in real time how much time each of them takes to do like output a response. But let me switch to the sequential process. And what I want to do now is basically the same question. I want to ask, very curious about what John's sort of like medication history is like, right? Or the active medications they are on. So that's the question, right? Here we have an AI agent, we have an LLM, and we have a RAG approach, right? So different processes or different approach. The agent, like Peter mentioned, the agent will basically only get the information it needs, right? It will basically iteratively, right, just get the information it needs, use the tool to actually like, get the relevant information it needs instead of ingesting all the data. Perhaps on the other hand, with the LLM will eventually just ingest all the patient data into sort of like itself and then try to like answer our question. But like we already mentioned, there's some models that have like very, very small context windows, right? And also, mind you, this happening on device. I can just switch off the mobile data. It also run. It could also run on a mobile device. And then we have the RAG approach where like staff's medical information are like embedded, in chunked, and then basically like retrieved using similarity scores and all that, right? Okay, cool. We've got a response from the LLM. That's cool. Let's wait on the other ones for a while. I'm pretty sure the agent will be next, and then the RAG. Yeah, so this was actually fairly quick, right? We were able to get like the information we needed to get back. It basically says, hey, the patient's current medications include this and this and this and this. So we have 4 medications. But then let's go back to FHIR JSON. So imagine you have a JSON like this, right, which represents like the patient's sort of like data, longitudinal patient data, like which goes like way back. Imagine there's like sort of like hundreds of thousands lines long, right, in your database somewhere, right? And then imagine like ingesting that into this direct LLM. So we are actually using Gemma, right? Yeah, so imagine like ingesting all that here. Would actually be pretty slow. And probably I'm pretty sure your phone will maybe like run out of RAM or something, right? Yeah, so here that's actually not an ideal approach because you actually want to get only what you need, right? Let's also take a look at the RAG approach. Can someone actually spot any sort of like anything here that actually looks out of place? Anyone? Like very quickly, anyone? Yeah, let me share the screen again. Let me open up the demo. Yeah, so here we have like all these medications. We have all these medications as well. Here we have like all these medications. Yeah, can someone spot like any sort of like difference, these 3 responses? Actually, I'm gonna call up names. Let's see. Oops. Yeah, anyone. You can actually just even type into the chat. Oop, I see Doc's hand up. Okay, Doc.
Yeah, so I think when you look at the two, the agents and the LLMs, it kind of, in a way, gives you what you want, like as in bulleted forms. But with the RAG approach, it has it in a narrative. So you would have to end up reading everything before you can extract the key medications from there. That's what I see just by inspecting the outputs there. Thank you.
Exactly. So thanks so much for that. Yeah, so like you said, and this goes back to what we already said, right? The agent actually searches for what it needs at the time you're actually making that request, and then gives you just that, right? But then, for example, with the LLM approach, it would have to like go through like every single sort of like patient data you've actually like fed it, right? And now try to like make sense of it. So if you see here, we're actually just talking about the medication, then now it's talking about like hypertension and all that and diabetes. We really don't need that. But then eventually it was able to give an answer, right? Similar here as well. But then the RAG approach, one thing I'd like to also point out is sometimes some information can get lost, right? Because you only get in sort of like top K something, right? So you can see here that not all the medications, although it did mention here in its reasoning, not all medications are actually showing here, right? Yeah, so there's also like a very, very like clear distinction to make, and the reason why we actually like using an AI agent instead of like any of these two approaches. So that's something I also wanted to sort of like point out. Actually like different sort of like ways, different sort of like approaches you can actually like use to make sense of sort of like medical data. But then we just didn't come up with like agents, right, for this approach. So yeah, that's something I wanted to point out really quickly. Doc, want to say something?
Yes, I just wanted to comment on this. Your demo that you just showed, right? Why do you think it looks like I'm looking at the runtime? The runtime, it looks like it's very slow. Yes, any reasons why? Or it's just
Yeah,
hardware? Should we just
yeah.
blame it on hardware?
Yeah, that's a really, really good question, right? So here the model we're actually using is a reasoning model, right? So that means that it basically tries to sort of like think through like the data it's basically given, right? And then try to like give you an answer. So let me actually show this real quick. Maybe the sort of like structured agent output. Let's do this once again. Let's get the medications. Um, and you can see that for the agents, right, it actually goes like lots of steps, right? So first, it basically tries to get the relevant patient data it needs, call the tool that it basically is relevant to the question, and basically like get the actual facts based on that, right? So basically sort of like filtering that data, and then eventually try to sort of like parse that in a response that's readable to the human, right? So for example, you could say, hey, it's quite unfortunate that our very first try gave like a bulleted point, but then um, for some other questions, it would actually like rub that in sort of like a natural language way, right? Or a sentence or paragraph for the user, right? So the reason why that is that it's actually going through like lots of process. So you see like the retrieval step itself is actually different, and then the parsing itself is also different. So the reason basically like acts sort of like a bottleneck is something we can actually like remove entirely from the agents. But then, yeah, to sort of like answer the question, the runtime is actually very, very slow because it's actually doing like lots of things sequentially by sort of like the agent with the tool calling and all that, and then eventually also like parsing that response in a way that's also like makes sense to the user, to the clinician, and then basically like structuring that. So you can see here that, hey, it was able to like extract some time relevant facts and information, basically gave it back. You can imagine like this being like a JSON, right? So it's FHIR JSON, and basically it can generate the response. And also we're actually using like function gemma. Function gemma is actually really good at like tool calling, but then when it comes to, for example, agents like this, you would eventually want like either like one model that actually does the function calling and the response, or you could have two models, right? The function calling model and then the LLM response model. So the reason why it's actually very, very long is the LLM response model is sort of like an overhead, right? So you can see that it's actually taking the time to actually like render all this information. Yeah, but then, yeah, I think to summarize, it's because it's actually going through like lots of steps. But then the advantage is that one, you're not like burning like lots of tokens, you're only getting what you want. And that also makes sure that you are not getting sort of like a hallucinated data, right? Or information back. So imagine with the LLM direct LLM response, it was basically like thinking about things that we even didn't need in the first place. But here you only pass the relevant data you need, although you actually go through like extra steps, but much more grounded in a way, right? Yeah, yeah. I think Justice also has a question.
Yeah, thank you. Just a follow-up. I just want to find out something about trade-offs. So, as a medical doctor, I ask a question, and then the agent tells me one, two, three, four. It ends there. LLM gives me a whole history, and then the RAG also gives me a whole history. As a medical officer, are you can I convince myself that going for the agent, these four elements is enough for me? Because one could see from afar that the LLM can give you maybe some other justifications to why these medications are taken. Should I prioritize agent over LLM, and why?
Right. That's a very good question. So yeah, I guess the crux of the question is, and also this goes back to like a point in our presentation where we also mentioned condition trust, right? So you want a way that you present the output to the clinician in a way that feels grounded. And like we saw, I think the direct LLM approach and also the RAG basically like give much more like background explanation and like all those reasoning and stuff, right? But then specifically to this scenario, we only asked a simple question. So we only wanted to get the medications. So you could imagine this for say a community of like or even like a clinician like yourself, let's say in a clinic somewhere, right? But then you want like an information as fast as possible, right? Let's say you want to basically like treat like a patient, right? And then you want like some context, right? You want like, for example, their medication just to make sure that, hey, I'm gonna prescribe this medication to them, but I want to make sure that there's no like sort of like drug interaction in a way, right? So you would want that as soon as possible. We're actually like reading through, for example, all the background data and all that, right? Because essentially you could also like query that information. I don't know if that answers the question. But then the crux
Okay.
of this, yeah, the crux of this was basically to help clinicians get, for example, information as quickly as possible, without, for example, also hallucinating. And also, yeah, speaking of hallucination, with respect to the direct LLM approach, although it was able to sort of like get all that background information, all that background data, medical data of the patient, it's also very likely for it to hallucinate, right? Although context helps, but then the probability that it also hallucinates also becomes much, much larger. Right. So now we are left with like two approaches. We are left with the RAG approach and then the agent approach. But then the reason why we specifically chose the agent approach in this specific sort of like scenario or use case is that we would only get the information we would need, right? And then based on information we get, we would eventually like parse that to the clinician in a way that actually like is readable. Yep. Please, is that
Okay.
clear enough? Does that clarify the question?
Right. So, yeah, that's fine. So you give the model something to tell you, and then we all were expecting the agent to be on time, but it came late. Why should I still wait for it to tell me something?
I think Justice was asking a question.
Yes. So I was talking about three algorithms, right? And the agent gave me three answers or four answers. LLM gave me a chunk of text, the same for RAG. And I have to wait several minutes to wait for to get the agent to work. But the other two gave me something pretty much short in terms of time, but more content. What will be the direction? Should I still wait for all this chunk of text or wait for so much time for just three words?
Right, right. That's a really good question. So one with the direct LLM approach, right? Okay, so the reason why we would essentially use the agentic approach is one, because we want to sort of like reduce resource usage. So for example, the number of tokens we are using and all that. We also want to get like much more grounded data. So yeah, let me actually make a present sort of like an illustration. Give me a sec. Okay. Yeah. So let's say we have our FHIR sort of like data, right? We have our resource type. I hope you can see my screen. Resource type. Let's call this patients, right? Actually, why don't we copy all of this? What we generated, that's actually a simulated patient data, right? Okay. So let's copy all this. up to identifier. Okay, let's paste this here. Right, let's zoom out a bit. Maybe in a bit. Yeah, so essentially the crux of the agent usage, right? This how it will eventually work. Let's say one, if asked about the medication, right? Okay, asked about medication. Now, the tool calling sort of like model needs to figure out, hey, what exactly was the question, or what exactly am I being asked about? So, what is the patient's medication? Let me scroll to the left a bit. Right. And then now it decides, hey, I have like all these tools in my arsenal. So I have get medication, I have get patients sort of like data. Maybe that'll give us like much more granular data. You have say get observation. Actually, let's use the resource that we actually talked about. And now let's say it gets practitioner, which will basically like give us information about like the practitioner, right, during like those observations. And then now the agent basically figures out, hey, okay, based on the question I was being asked, there's the relevant tool I need to call, right? And then essentially what will be passed in is say the patient ID, right? Patient ID to the tool call, to the tool eventually, right? And then now we get sort of like the information we need, right? And then now we basically sort of like synthesize it. Right. So whereas with the other approach, let's take the direct LLM approach, right? What happens is that you have like all this data fed into it, right? You have all this data fed into it, right? And then it's basically gonna pass through or sort of like check the data one after the other, right? And give you some answer. Well, that would, if the data is like small enough, it will actually be very, very quick. It will also like give you like an answer. Sometimes it also like if it's a reasoning model, also some sort of like explanation, right? But then let's compare these two approaches, right? Here we ask some like a specific question, which is the same you're asking here. And then here, it first checks the tool it needs, right? And then gets the patient's information that basically we asking, right? So that would be step 4. So 3 and 4, right? So eventually, the room for error, right, here is very, very low because we are only restricted to, for example, the data that we asked about, right? So whereas here, we actually have all this information, and if the LLM is unsure about something, it's actually almost going to make it up, right? So let's say we asked about, say, the patient's labs, right? Now it's going to talk about, hey, patient has hypertension. Now let's talk about the patient medication. Okay, based on the patient's sort of like diagnosis, plus say medication. Although I'm not sure, but hey, I guess just gonna give let's say the patient did like a chest X-ray, right? So you can see here that the the reason why basically we actually using like an agent for this use case is the room for error here is actually very, very small because there's only so much data that we've actually provided the model, right? Whereas here, it's actually a lot that now the agent starts basically hallucinating, right? It's sort of like inferring data from sort of like some data we provided to it, right? So yeah, I think that's actually a great point. And also there are also like further rooms to actually also optimize the sort of like agents. I think the sort of like downside of the agents is it goes to like several steps to make sure that it basically gets the information it needs, gets the tool, or basically query the tool it wants or needs for that task and then get it back. I think we can actually sacrifice a bit more or a small amount of time, right, to be sure that the information that the clinician is actually like getting is actually grounded, much, much more grounded, right? Because I think like we talked about in our previous points, the last one was clinician trust. You actually want the model to output something that is actually like grounded in a way that would sort of like let like clinicians actually trust the model, not more, but then also serve as sort of like a second reviewer in a way, but then also make sure that, hey, this response that you gave actually makes sense based on like the information that I asked right here and now. I don't know if that answers the question in a way. I know I was
that's
going on and on
fine.
and on.
Yeah, that's fine. That's fine. Thank you.
Yeah, for sure. Are there any follow-up questions?
Yeah, I just wanted to add to this particular one. I believe that looking at this, the main thing is accuracy, right? Like you were saying, in the medical space, yes, accuracy is key, right? So in as much as the this thing is given very small or very limited information, the degree of certainty is high. But I believe that, you see, in a typical production environment, you'll be doing very optimized orchestration and all that. So at least that, in a way, can increase or improve performance. Yeah. So we might be seeing about, let's say, like 10 seconds generation time or something, but with very robust pipelines in place, we should be seeing, like, yeah, able to reduce it to the milliseconds, I guess. Yeah, so
Right.
that's basically that. I think that with what he's looking at is more of the grounded, or how grounded it is in the information that was given to it. But yes, production is also a different environment. Yeah, so yes, I think we can continue. Thank you.
All right, for sure. Thanks for that, Doc, and thanks for the question, Justice. Actually, just unrelated. Also, there's a tool called Lang Extract. Maybe if anyone of us is curious to sort of like check it out. It's actually like a tool that provides like grounded data, right? So, for example, if the LLM says, "Hey, there's a medication," basically what it enables you to do is infer exactly where in the report or basically patient data that inference was made, right? So you can actually like backtrack to that data, then basically like track exactly where it was mentioned, basically, right? So this basically unrelated, but then if anyone is curious, basically for LLM like sort of like grounding in a way, this is actually like a very also really useful tool, right? Okay, that's just by the way. Let's get into it. Okay, cool. Yeah. All right, so we've touched on like all these. We've looked at, for example, LLMs, RAG, AI agents. We did, for example, the demo about like all three, talk about like the pros and cons of all of that, which was pretty interesting. So maybe let's dive a little bit like deeper into sort of like what the agent was doing with what we just showed. Let me cut out of this for a bit, and on the background. Oh, we even have this. Okay. So we have like 9 steps. Basically, like we said, basically like gets only the information it needs and basically extracts the relevant factor that it wants, right? So let's look into that pipeline a bit more. Okay. Yeah, so we have the first step, which is basically to perceive, right? So you receive the task. That's basically the first step, right? Then you plan. So basically now breaking the steps or the tasks into like different steps, and then you act. So the act is basically like the tool calling model, basically like calling the relevant sort of like tools or like endpoints to sort of like get information from, right? And then now you flex, right? So you sort of like reason the model reasons about like the data that I got or the response that I got, making sure that there are actually no gaps, it's actually grounded, and then you deliver that in a response that is actually makes sense or suitable. Yeah, so maybe there's like a slide worth looking at about like different places you can actually like use these different tools. I think before we also looked at something similar. So imagine, for example, a patient arrives at a clinic. The doctor wants to basically like look into their records, for example, their medications, their medical history, observations, and all that, encounter and all that, right? So the agent autonomously goes to all the record and then retrieves only the information it needs, right? And I mean, you could actually use this across like everything, but then it also basically helps to also make sort of like distinguish between where exactly to use what, right? But then, yeah, also you have like consulting, basically surfacing like guidelines based on conditions. So I think like you saw in sort of like the demo, at the very top, there was like a flag that said, hey, there's a possible like drug interaction between like this drug and then this drug, right? And there's something like worth looking at. So specifically when it comes to like clinical decision support, mostly RAG is actually very useful because it actually like retrieves sort of like guidelines. So for example, WHO guidelines for specific conditions as well, right? It's also like very useful for diagnosis when you want to cross-reference symptoms and labs. So not just looking at a specific encounter or a specific sort of like resource, but then maybe you want like the encounter and sort of like the labs as well, medications as well, and all that, right? And prescribing as well, with like agents, you first have to check drug interactions and basically checking coverage, right? You have documents, you want to draft like clinical notes, clinical reviews. This is where documents actually LLM actually perform like very, very well. I think with the EHR system, we actually chat EHR from Stanford that we actually talked about way back in the beginning of the presentation. And follow-up as well. So basically, they actually perform very well at places where you want to basically do things autonomously and also basically iteratively, right? So it doesn't just stop at a step, but then actually like goes on to finish the task in a way using like the relevant sort of like tools it needs, the relevant context it needs, and the relevant data it needs, right? Yeah, we actually started from a very, very long place, talking about like FHIR records, talking about basically solving the infrastructure problem, right? Talking about basically how to solve for the infrastructure problem, talking about how to structure and standardize the data, how to layer intelligence on top of it, and basically generate insight from it and all that, right? But there's also like some things that we also like need to look at, right? It's also worth taking a look into some of these things. AI agents or like AI in general, still has like a long place to go. There are still like gaps. So basically, most of the time, although you may have actually built like the infrastructure in place, sort of like built the ground and all that, right? But then there are also like possible ways it could still go wrong. So it's worth also taking a look at some of these things. The first one is hallucinations. LLMs generate things that are not factual. They make things up, right? So I think Lang Extract, guys, check it out. It's a really cool project, basically grounding sort of like data in some of the documents it's given, sort of like grounding it in and referencing it back to exactly where it's with and all that, right? And also specifically, sometimes there's also like retrieval noise, right? Basically pulling irrelevant or outdated records. So let's say with our third column, which represents a RAG, we ask for medications. Let's say the clinicians actually ask for present or active medications. There is a possibility that it would actually retrieve inactive medications, right? That was something worth looking at, especially with agents. There's over autonomy. Can actually act without checks. For example, if it give sort of like an agent's permission, especially since this is healthcare, if you give it like permission to, for example, modify patient data and all that, sort of like that level of autonomy, sometimes it could also bring problems. So it's also very, very like key to always have like a human in the loop. So the agents or AI does the first step and then the human reviews. So yeah, maybe this unrelated, but then I want to chime this in that, for example, if you have like a diagnostic of like two that scans for or triages chest X-ray, for example, let's say, hey, there are only 93 radiologists in Ghana, right? Okay. You're a developer or you're a clinician with like a tech background, or maybe you have like some developer friends. Want to solve that problem. I'm going to build like a sort of like diagnostic tool on my phone, that would basically like capture sort of like a text X-ray form, right? And then basically draft a report or basically also detect some sort of like anomalies, right? It's very important to have like a human in the loop. There was this recent sort of like research I was looking into, basically how radiographers and even like community health workers can basically help with the triaging of like some of these sort of like these diseases. And it's important to keep in mind that while these models are sometimes good, they are not perfect yet. And especially in healthcare, you would want some expert opinion, right? So no matter the accuracy that the model has or whatever, you always want like a human in the loop that actually verifies the model output, right? And also like data privacy. That's why we're actually using Cactus and some of the like there are actually several on-device inference engines and all that, right? Basically to make sure that the data is not like leaving or basically touching sort of like a server is not supposed to touch, for example. And also ensuring that you're actually complying to data protection laws and all that, right? So yeah. And I've talked a lot about this, especially stayed on the slide for a while. But then the key takeaway is that AI basically recommends and then the clinician decides. So no matter how perfect the model gets, there always needs to be like a human in the loop to actually verify the outputs, right? I don't know how much time you have. Doc, do we still have time? Maybe we could actually dive into the technicalities of the Cactus SDK, but basically Cactus is an AI inference engine for wearables and on sort of like edge devices. So instead of relying on a cloud third-party API, you could have like the model on your device, could be your Mac, your phone, your wearable, could be your smart glasses or your watch. Yeah, so I think what we're actually going to do here is basically like look into the code about especially how easy it is to actually have your own model, right, on your own device and how you could actually like utilize it for especially some of the things we've talked about and some of the things we've seen. So I'd like to clarify from Doc if we still have some time. If we do, we'd go very quickly into it.
Yeah, so I don't know if you can finish everything in like 10 minutes. Yeah, because so that at least we can take some few questions, 1 or 2 questions, then we'll call it a day. Is that enough time to do what you want to do?
Yep, that sounds good. Yeah, that's enough
Okay,
time.
sure,
Okay,
sure,
thank
sure.
you. All right.
Thanks.
Yeah. Yeah, so Cactus is actually a I can provide the also the slides and everything would be shared. So basically it's an AI inference engine for edge devices. You could essentially like run some of these super cool models on your smartphone very, very quickly to do like very, very useful things. So yeah, here let's look into why exactly we would need that. So one, especially in healthcare, you might want to sort of like comply with like data protection laws and all that, right? So for example, if you're doing sort of like some triaging or diagnostics or whatever, you want that to be done on device, right? Also works offline. So imagine a community health worker in sort of like a clinic somewhere with like unstable internet connection. That would really help. Also, it's multi-platform, so no matter the platform you're on, Android, iOS, basically it actually supports that. So it's a really cool model. Check it out. Let me move on to the next one. Yeah, so very quickly, let's go through the code. What we want to do is we said about FHIR, right? We said it's just a JSON, right? So you could essentially, we already created sort of like a simulated FHIR data, right? So essentially what happened, especially with the demo, is that we created like sort of like a class, right? Which represents sort of like the different FHIR resources, right? So here you can see we have the patients class, right? And then you could define your own schema, but then it's also really relevant to say that this schema is actually based on the simulated data structure that we had, right? So there are actually libraries that actually help you like do this very seamlessly, but I want us to basically sort of like pop the hood up and then look like deeper into what exactly is sort of like happening in the backend, right? So you define sort of like the ID, the gender, the date of birth, the name, and all that, right? And if you want to pass sort of like the some sort of like accumulated information, so sort of like the full name, so like accumulate them or concatenate them, right? So that's what it looks like. That's what you get. Let me scroll way down. You have like the JSON, and then there's basically like what you get as an output, right? So you have the resource type, which is the patient, and then you have the ID, and then you have like the name, the gender, the birth date, and all that, right? And you can actually have like a different resource type condition, right? Or also has like an ID, the code, the clinical status. You also have like a different resource type, right? Which is like the medication request and all that. So I just wanted us to basically look at just how easy it is to actually like structure your own sort of like FHIR data structure and all that, right? And also with Cactus, it's actually very, very easy to actually start using a model, right? So you basically just have like your sort of like function or class or whatever, right? First, you download the model and then you initialize it. That's really very easy to do this. First, you basically call the download model or function, right? I know this can be confusing or method. Yeah, so you have that, and then basically you specify, for example, the model you'd want to use, right? And then basically it would start downloading on runtime when the application starts, right? And then you basically initialize it. And then if you want to basically have like an LLM sort of like completion or sort of like chat or whatever, so pretty straightforward. And also there's like code base and slides will be provided after the session. So don't worry about that. So we have the chat message, which basically specifies the system prompts and all that. Yeah, so you have like the messages, which is like an array of the system prompts and also the user message, right? And then right from here, you can actually like start like getting an output from the LLM, right? And then specifically, I think if actually like use ChatGPT or whatever, the response comes like as it's generating, right? So basically like streaming, right? You could actually do that here. So with the LLM, sort of like conversational one, you just use the generate completion method. But then if you want sort of like some streaming capability, it's gonna be like the generate completion stream, right, method. And you can actually generate embeddings. It's also pretty easy to generate embeddings and also like use RAG on Cactus. They have the Cactus RAG, where you just like have your document uploaded somewhere and then reference it, right? And then you can just call the API, and then you can just like do some RAG with it, right? And then yeah, what we've been doing, right? We have the tool calling, right? So with the function JAMA model, so essentially what you do is you just define your tool. So like we just saw in the demo, you have like your tools in your arsenal, which you define, you give me like a description to, right? Which does something, right? And then the agent eventually, based on the query, figures out, hey, this is the tool I need to call based on the question I've been asked, get the relevant data, passes it, extracts the relevant information, and then synthesizes it, right? So pretty cool stuff. This an example. Once again, you can go through the code anytime you want when we provide the link to it. Yeah, and then maybe lastly, we can touch on the agentic pipeline. So here, let me maybe go back a bit. Yeah, so one, you'd have like your sort of like tools in a registry somewhere, and then basically you have like the agent loop, right? And then that eventually like iteratively like call the necessary tools it needs, right? And then basically like give like the expected response or whatever, right? Yeah, this is super cool. There are like 5 files here, which will basically, or 6 files, which will basically like simplify everything we've talked about. We also have the Synthesia exploratory like notebook, which you can also like take a look at if you want. But yeah, I'd like for us to end here. You can take a look at the code base. You can also run the app locally on your phone or Mac if you want to. So we'd provide like links to that. And yeah, I'd like for us to end here. And if there are questions or anything, I'd be happy to answer them and for us to discuss. Okay, thank you guys so much.
Okay, so thank you very much, Dr. Champo. Okay, so yeah, so please, any questions? Any questions from Samuel? Is it for Samuel? Okay, yeah. So I think someone was talking about Cactus. Samuel, did you place like second or something?
Yeah, Doc, I placed second in the hackathon. Yep.
Okay, fine. So it means that for the Cactus challenge, the whole world you place second.
Yes, Doc.
Yes. So it means that we had a very good resource person in here today to take us through stuff. But yeah, it's been insightful. Basically looking at the angle where we had to do the comparison, basically. Yes, and I also think that for the FHIR, right, the FHIR tool is something that maybe all of us, or most of us, right, didn't really know of, and now that we have that in our arsenal, it's going to help us with coming up with these creating systems that are interoperable, basically. Yeah. So what I would say is would like to thank you for the opportunity to take us through this. Yes, health tech. Yes, and one thing that makes me let's say like Samuel's zeal is, you remember we when we shared our maternal health data set, within like 24 hours, and someone had shipped a chatbot that's Motherline, right?
Yes, Doc.
Yes, that's was consuming, or that was using the data set that we had pushed out there. So it clearly shows that yes, Ghana, we don't lack innovators. What we lack is context, contextual data, right? Context data for our environment, and yes, we'll be able to contribute immensely to this whole AI craze. Yeah, so thank you very much. I hope that I think we'll share the material. The video will be worked on and posted on YouTube. We'll also get the things loaded on GitHub. We'll get Samuel's GitHub details with the application and the slides. And so we'll add it to the description of the video once the video goes live on YouTube. Yes. So I don't know if there are any additional announcements to give. Alidu, please. Is there any additional announcement to give? Okay. Yeah. So I think Alidu is not available now. Yeah. So yeah, I would like to thank you all once again for joining us. All right. So Samuel, thanks.
All right,
Enjoy
Doc.
the
My
rest
pleasure.
of your day, please.
All right. Thank you, everyone. Yeah, hopefully we meet again. All right. Bye.
Yes. Before, I think Samuel's is on LinkedIn. Yeah, Samuel is on LinkedIn. So if you have any questions at all beyond this, you're working on any project, you see he posts a lot of things on there. So if you see that he's posted something you're interested in, you could reach out to him on LinkedIn, Samuel Donkor, and just worry him a bit, right? So thank you very
Yeah.
much. Okay, then. Bye.
All right, Doc. My pleasure. Thank you all for having me. All right.
Thank you.